in the presentation today. So there will be a very short introduction of INF and then myself as well. We'll have a look at some maternal, newborn and child health data in Nepal just to set the scene. We will have a look at some of the perils and progress in MNCH in Nepal, talk a bit about the real importance why we focus on that topic. We will explore some of the context and challenges by using a case story. And then I will introduce you to INF's working modality. What are the strategies that we use in our community-based MNCH work? I'll give you then another short case story and then finish off with looking at the challenges that are ahead of us. And then, as Ben already mentioned, there will be the opportunity to ask questions at the end. So, INF is as Ben already said, it's a Christian mission organization that is serving the physical and spiritual needs of Nepali people. And it's an NGO that has been operating in Nepal for over 65 years, so very well established. And there are two main areas that we are working in. One is more clinical work, so we have 3 hospitals. And then we also have very extensive community work. And you see here the map of Nepal, and all those red dots represent districts where we work in our community work. And a lot of those districts are in the Midwest or Far West because they are the most remote and marginalized areas in Nepal. Oh, I forgot here. So the vision of INF is to provide life in all its fullness for Nepal's poor and disadvantaged people and communities. So just a little bit about myself. You can see this screen is very colorful, very varied, and that's basically how our life in Nepal is. It's very colorful, it's very varied. So my husband Neil and myself, we've been in Nepal for the past 3 years, and we are currently based in a town called Nepalganj, which is in the Midwest. You see that it's a pretty good reflection of Nepalganj here. So it's a, if I had to describe it, it's a dusty, hot, smelly border town to India. So when you look at it for the first time, not very appealing, but if you dig deep enough, there are a lot of gems to be found in this place. So my role within INF Nepal is public health advisor, and I work across the organization. I'm based in Nepalganj, but I work across the organization, and my special task is to build the capacity within the organization for implementing maternal, newborn and child health projects, and to ensure that that work is done at a high quality level. So I'm involved in training. This picture here was taken at a workshop that we had earlier this year, where we brought together 25 staff from all different areas and updated them on the latest evidence in maternal, newborn and child health. And a lot of these people work in very, very remote and isolated areas, and opportunities for professional development are not really there. So part of my role is to support the MNCH work with training, and then also work with the managers, with the Nepali managers who implement the projects. So together we look at how we can do that most efficiently with the limited resources. And I'm involved in some donor communication, trying to get funding, help with reporting and those kind of things. And then I also get the privilege, that's what you can see down here, to go out. So a lot of my work is actually in the office and working with the managers, but I also have the opportunity to go out and visit mothers groups like this one here in a place called Jumla, and just sit with the women and have a conversation and see what this work, what being part of that work means to them. So let's just go to the next screen. So I think we're just going to set the scene a little bit, and I don't want to give you a lot of data. We can find that anywhere on the net, but I thought I'd just set the scene a little bit with some of the statistics that are there, comparing data from Nepal and Australia. So, for example, when we look at infant mortality rates, that is, out of 1,000 children that are born, how many die in the first year? So in Nepal, we have the number 28. So the infant mortality for Nepal is 28, as in comparison to Australia, that is 4. So we can see quite a big discrepancy there. When we look at the maternal mortality rate, that is measured per 100,000 live births. In Nepal, we have 258 women die per 100,000 live births, as compared to Australia, that is 6. Children under 5 that are underweight, 30%. So every third child in Nepal under 5 is underweight. In Australia, there's 0.2%. Contraceptive prevalence rate, 40% in Nepal, 72% in Australia. And when we look at the Human Development Index, which is a combined indicator looking at life expectancy, education, per capita income in a country, then we can see that Australia is and has been for quite a while number 2 out of the 188 countries, and Nepal sits at 144. So that just gives you a little bit an idea about what the situation for maternal and child health is in Nepal. So let's have a look at what's been happening in Nepal historically. So the Safe Motherhood initiative of the World Health Organization started 30 years ago. I think they had their 30th birthday last year. Nepal signed up to the Safe Motherhood initiative not 30 years ago. It was quite a little bit later. And that was the first really big effort to try and improve maternal and child health in Nepal. And one example how Nepal tried to address that was they started an incentive scheme. So women would receive a payment if they go for 4 antenatal care visits. If women would deliver in a health institution, they would also get a financial incentive, and they would get some travel money as well, because utilization of health facilities was very poor. And that's actually achieved quite good outcomes. Also, health facilities received and are still receiving financial incentives for deliveries that they have in their institution. Then a big push for maternal and child health was also happening with the Millennium Development Goals, and Nepal set their goals and really worked very hard to achieve them. And one very big strategy that was used was developing or training health professionals. That was as skilled birth attendants. So there was a training package that was developed for health professionals, and they were trained in some midwifery skills, and yeah, they call it SBA training, skilled birth attendant training, and it was for doctors, nurses, auxiliary nurse midwives, and that was a very successful strategy. And it was really, again, a very strong push for institutional delivery, trying to achieve 4 antenatal care visits, and also postnatal care was introduced. And Nepal was very, very successful with reaching their goal around maternal and child health. And just to give you, I don't know whether you see that on your screen, but if we look at 2011, The blue line is number or percentage of women that had one antenatal care visit, and we can see that's gone up from about 65 to about 85 in those 4 years. And the goal is always to have 4 antenatal care visits, and they have gone up from 50% to 70%. So that was quite an achievement. And a very big, huge achievement was cutting down the maternal mortality rate. So in 1996, that was sitting at I think 586, something like that, close to 600. And in 2015, that had gone down to 258. So really great achievements during that time, during that special focus of the Millennium Development Goals. So that is wonderful. However, if we actually look at the in-country gains that were made, we can actually see that there is a great inequity within Nepal. So a lot of the efforts during the Millennium Development Goals were made to achieve those goals. So a lot of investments were made in urban areas, in easy to reach areas, and the remote and marginalized areas, they were lagging behind and were forgotten. And in some areas, the statistics actually went down in those years. So just have a look at that graph that I have here. So if you look at 4 antenatal care visits, red representing the urban and easy to reach areas. So it's 4 antenatal care visits, we're sitting somewhere around, I think, 90%, but in remote and marginalized areas, we're only down at 40%. So there is a real big gap. It's even bigger when we look at who delivers with a skilled birth attendant. Very, very huge gap here. Same for postnatal visits. Great achievements for the urban and easy to reach areas, but very poor indicators in the remote areas. The only area where remote and urban do really well in Nepal is immunizations. And so we have, and always had, like for many, many years, very good outcomes in immunizations. So that kind of shows also the importance. I told you when we looked at the map before that INF works a lot in those remote and in remote areas with marginalized people, and I think this gives a very clear explanation why we are doing it, because that's really where we want to see improvements and achievements. So we've seen a lot of progress in maternal and child health, as I just said. So why are we continuously concerned about this? Why is this so important? Why is maternal and child health so important? And despite great gains, we have to say that the mortality and morbidity figures are still really unacceptably high. So they are still, out of 100,000, there are still 258 women dying. There are still children dying. And the very tragedy is that a lot of those deaths are actually preventable. So with relatively easy measures, we could avoid or prevent those deaths. So things like bleeding after birth, infections, obstructed labor, all those things that cause morbidity or mortality could actually be addressed. Then one other interesting factor is that even in low and middle income countries, we are seeing a rise in non-communicable diseases. I think it's not a rise in those non-communicable diseases. I think they have always been there, but 10, 15 years back, we were very concerned with infectious diseases, so that we didn't really focus on those other things. And now that a lot of infectious diseases are under control, we see that non-communicable diseases, chronic diseases are really also a very big problem in low and middle income countries. So I'm talking about diabetes. We see a high diabetes rate in Nepal, heart disease, kidney disease, all those conditions. So I don't know whether the people that are listening tonight here, whether they are mainly medical people or not, because if you're not, you might be wondering, what do the non-communicable diseases have to do with maternal and child health? There's actually something, and I put the letters here, called the fetal origins of adult disease. So there is a connection between chronic conditions that people develop and the prenatal period. So we know now that malnutrition prenatally has a strong link also with developing those non-communicable diseases later in life, which means if we can address malnutrition in pregnancy, we can actually avoid some of those things from happening later in life. One other point that I put in here, and I put it in gray because I wasn't really sure how that fits in there, and I have to say that we as an organization are also not yet too sure how we work with that. But in actual fact, in Nepal, suicide is the #1 cause of death for women of reproductive age. That has been discovered or found out about 10, 12 years ago, and we don't really know a lot about it. We know those statistics. We know and think it has to do with family issues, domestic violence, dowry disputes, and young women just feeling very powerless, and that then leading to severe mental health issues and to suicide. So I don't know how that can be addressed, will be addressed, but obviously that's the age group of women that we are working with in maternal and child health. So that could be also quite a good way in to address that, that high suicide rate. And then as a fourth point that really shows us the importance of maternal and child health is the significance of what we call the golden 1,000 days. So when we talk about the golden 1,000 days, we talk about the 1,000 days from conception up to the second birthday of a child. So that's about 1,000 days, give or take 2 or 3. And we know, and research has shown, that if nutrition goes well in those first 1,000 days, we're actually building a very, very strong foundation for the future and for the health of those children. And I'll just show you some of those statistics here, some of the research that has come out of that. So children who get the right nutrition in their first 1,000 days from conception up to the second birthday are 10 times more likely to overcome the most life-threatening childhood diseases. That's pretty strong. They are more likely to complete 4.6 more grades of school, leading to 21% more wages as adults and more healthy families. So if we're looking at those statistics, we can really see how investing in the golden 1,000 days, how investing in maternal, newborn and child health can really have a very big impact on the health of people. Now, that all sounds very convincing, I think anyway, but it's not always easy. And I would like us to look at some of the context and some of the factors and some of the challenges that we face and some of the things that can impact MNCH outcomes. I will read you a story, and I would like you to listen very carefully, because when you listen to this story, you will become aware of quite a number of things, challenges, factors, and some context that have an impact or a negative impact on maternal, newborn, and child health outcomes. So this is Sushmita's story. Sushmita's bowl of rice sat before her, soaked in brownish dull water. With nothing else to eat and eyes closed, she plunged her fingers into its heart, forcing herself to eat. A sharp kick in the ribs reminded her of her unborn child. What she had just eaten returned. Tears streamed forth. At 16 years of age, married to a man she didn't know, with a family in which she was relegated to the lowest position, while feeling imprisoned in this mountain village. Sushmita felt more alone than ever before, unable to find the energy to continue her day until the demand to work from her mother-in-law broke through her silence. Knowing the importance of birthing a son only multiplied her fears, for she knew nothing about such things. And with the health post 3 hours walk away, she would be unable to go on that journey. But her mother-in-law repeatedly assured her that she knew all there was to know about birth. Despite Sushmita's attempts to make friends in her husband's home, she was led to believe that the extreme darkness of her skin and with a poor dowry, she was worth nothing. With her husband working away across the border, no one was there to protect or speak up for her. Despite poor food and heavy labor, she continued to rise at 4 every morning to work in the field before returning to ready dalbat by 10. The rest of the day she was busy gathering wood, finding leaves for the goats, and cleaning and preparing the evening meal. Her days seemingly grew longer, the work more difficult, while she tried to meet the family's demanding expectations. Resigning herself to her place in life, returning home to her parents was not an option. A health worker announced an intended visit to the village to check on pregnant women and babies. However, on that day she was forbidden to see them. Her mother-in-law was adamantly stating that the old ways were the best ways. Sushmita was to give birth by herself in the shed out the back, lest she contaminate the house and bring bad luck to the family. So, listening to that story, I would think that you possibly have identified a number of factors that we can see impacting on MNCH outcomes. Factors such as poverty, geographical isolation, the social disadvantage of women, low status of young women, harmful cultural practices, malnutrition, insufficient health services or underutilization of health services, and also lack of awareness of the importance of maternal, newborn, and child health. So these are the very realistic challenges that we are faced with, and I would like now to talk you through how we in INF, what the strategies are that we are using in INF, what our working modalities are of our community-based MNCH work. Now, bear with me, it looks a very busy slide, but I will talk you through this. So in INF, we use a three-pronged approach. We work with the demand side, so we implement demand-side interventions. And I'll talk a bit more about that. We work with the supply side and have supply-side interventions. And in addition, we also focus on nutrition. And I talked already about the importance of nutrition. So what does mobilizing the demand side mean? So that means we really work with the community on some of the issues that we just heard about. addressing, talking about harmful cultural practices, talk about the importance of maternal, newborn and child health, talk about the importance of antenatal care, talk about the importance of giving birth with somebody, being assisted by somebody who has a training, talk about the importance of antenatal care, taking your child for checkups and things like that. We work and mobilize a number of community volunteers. We work with mothers groups. So each community has a mothers group that meets once a month, and we work with them on a lot of those education issues. Income generation support, where possible, we give as well to address the issue of poverty. And one very important point with the demand side interventions is we don't just focus on the young women, but we have a whole of community approach, because I think it came out in that story of Sushmita that it is very often not the young woman who can actually make decisions about her healthcare or the healthcare of her child. It's the mother-in-law, it's the husband, it's other family members who really have a say. So it's very, very important that we work with the whole community. We work with families. We try to really engage husbands and fathers in our work. We work with, or try to work with, political leaders, religious leaders, people that have influence, and that can actually also over time change some of those cultural norms. So ideally, if we do our work well on this demand side with the community, ideally we have women and children accessing health services more. And so if we have all these women and children starting to go for their health care to health services, we also have to make sure that the health care that they receive is also of a good standard. So we work very closely with existing government health facilities and really support them and build their capacity. Sometimes the facilities need some upgrade. I still remember the first time somebody took me to a birthing center in Nepal. The word birthing center, you have some kind of maybe expectation what you will find there. I knew it wouldn't be like in Australia, but I was actually quite shocked to see what I found there. It was just a room somewhere off the side with a rusty bed in the corner with stirrups, and that was the birthing center. So if we encourage women to go there, we want to make sure that they're received well, that they're treated with respect, that they get the medical care that they need. So training is a very big part of that, and also management support. So all of those things in order to ensure that there is high quality service. Now there are some crossover issues between the community and the health post, or the demand and supply side. Things like transport to a health post and a referral system is kind of in between, and we try to come up with innovative ideas to address that. Then we work with every health post in Nepal has or is supposed to have a management committee, and that's members from the community who have, who have a say in the running of the health post. So we train these community members and build their capacity so that they can really monitor and support the health post. And then in some areas, like in the example of Sushmita's situation, we could see that there was a 3-hour walking time from her home to a health facility, and obviously we cannot expect somebody who is in labor to walk for those 3 hours. That's climbing mountains and going through valleys. So one other issue that comes up sometimes is having waiting homes, or having a waiting room that is attached somehow to the health post, where a woman and a carer can just go in the last 1 or 2 weeks before she's giving birth and just stay there, so that they're close to a facility. So, and then the third area that we work in, and I think I talked a lot about that before, the importance of that is also to increase the intake of nutritious food, because that is very, very important. And some of the activities or interventions that we do there, we work with community groups trying to promote kitchen gardening. We try to ensure that women and children have access to micronutrients, that iron is available for women, that vitamin A is available for children. Talk about exclusive breastfeeding for the first 6 months, and then we also do quite a bit of training around protein-rich weaning food for children. So there is some local way of preparing what we call super flour in Nepal, where local ingredients are used, and relatively easy to make a very a weaning food that is quite high in protein. So this all sounds maybe a little bit theoretical. So I've prepared another little story for you. And actually, let's go back. So the story of little baby Deepak will kind of come out of a little bit this area: mothers group, community volunteers, and awareness raising. So let me just read you the story from baby Deepak. I met Tulsi on one of my visits to a mother's group. During the meeting, I asked if the group had an emergency mum and baby fund. They proudly showed me their exercise book, which they used for bookkeeping. With the help of our INF staff, the group had established a fund 18 months ago where members could access money if they or their baby needed emergency treatment. Money would be made available immediately and had to be paid back within 4 months. On asking if anybody in the group had used the fund, Tulsi proudly told her story. She delivered her son Deepak prematurely at 8 months. He was very small, had breathing problems, and was not sucking. The doctors had little hope for him to survive and suggested to take him home, as they knew she was poor. However, there was also the option to have baby Deepak admitted to the neonatal care unit, but this was expensive. Tulsi knew she could borrow money from her mother's group emergency fund and requested baby Deepak to be admitted. After 3 weeks and 12,000 rupees later, Deepak had gained weight, was drinking, and was discharged healthy and well. Tulsi proudly told me that her extended family managed to pay back the loan within 4 months. My mother's group has saved my baby's life. Thank you, INF and staff, for your work in our community and for your love and concern and for teaching us in our group. Because of you, I have a son today. So it's always very encouraging to hear these success stories, these stories where we don't only change lives, but we actually do save lives with this work. And I just want to close this formal presentation by looking at some of the challenges that are ahead of us. Recently, a few months ago, we did a little research project with the help of one of our Nepali interns, and we looked at maternal, newborn, and child health indicators in our 12 working districts, just to see what the situation is. And we identified a lot of need. Basically, all 12 of those districts are in urgent need of some more focused maternal, newborn, and child health work. So a lot needs to be done. Ideally, there would be lots of funding, lots of staff, lots of projects, but I think we all know that reality is different. So we need to really be wise and look at ways how we can address that need. One big challenge within the MNCH work is addressing some of the contextual factors. We looked at some of the challenges before in the presentation, and things like changing cultural norms, poverty, some of those things that are really not easy to address and that take a really long-term approach. That are some of the challenges that we are facing. And thankfully within INF, in our community work, we also do other projects like income generation support, livelihood support, and that comes in quite well. And I think we need to see within our organization how we can integrate some of those projects and how we can utilize groups and networks that we have through other projects, and by bringing them together, how we can really maximize some of those outcomes. So we can use existing, or we can look at using some of those existing projects and networks, but at the same time we also need to have, in addition to that, some very targeted approach. I talked before about the health posts, for example. We can't just work with the community and the community groups. We also have to invest in the health posts, and those need to come together. Then looking at INF and INF's history and INF's work, I think we are very well placed to address maternal and child health in Nepal, because we, as I said before, we're working in 12 of those districts that are very disadvantaged. We have very good networks and relationships with the government, with community groups. We are well received there. And we also have really a growing expertise in the field of maternal and newborn and child health. And some of our other projects already address those underlying factors. So yeah, I would just like to close this formal presentation by saying I'm very excited to work in MNCH. I'm very passionate about it, because in this work we're not only changing lives, we're actually saving lives. Thank you. Ben, can I hand over to you?
Thank you so much, Inge. That was wonderful. There's been a couple of questions as we've gone, but just so people know how we're going to go here, if you've got a question, can you please flag it in chat, and I'll unmute people one at a time. That way we just don't have a lot of feedback or difficulties on the line. We've got two already, so I'm going to go to Constance and then Cherry, but if others are thinking of questions or even just comments or reflections or feedback, please feel free to just flag your name in the chat pane, and I'll throw to you in a moment. So Constance, you should be unmuted now. Constance, can you join us by audio, or do you want me to ask the question for you? Constance's audio seems not to be coming in. That's all right. So Constance had two questions. One related to what was the exclusive breastfeeding rates in Nepal, and do mothers need lactation support, and what kinds of support do they need? And the other was just, she asked if you had any more reflections on what sort of harmful practices and how they could be addressed. And that also relates to Cherry's question, which is, what do you think are the best ways to address cultural practices that affect MNCH outcomes? So exclusive breastfeeding and lactation support, and then harmful cultural practices.
Thank you. We don't see a very big need for lactation support. That seems to somehow work quite well, or at least we don't really see the women. Now, exclusive breastfeeding for 6 months, the rates are, I just think back of one of the baseline surveys that we did for our project, and that was around 60%. So very often it's not necessarily solids that are given early, but very often it's things like water or milk or some other things given. And obviously water is a very big issue because, you know, water in those areas is not the cleanest. But yeah, so about 60%. And lactation support, yeah, we haven't really seen a lot of need there. Don't know whether that answers your questions, Constance. So the next one was around harmful cultural practices. There are a few where we can see a direct impact. One of them would be early marriage. So we still see, officially it's no longer allowed, early marriage, but early marriage leading to really early pregnancies, leading to very, you know, young girls having their first baby, leading to all kinds of complications, but also leading to all those, you know, mental health issues and education being interrupted, but also to leading to those direct complications, birth complications, obstructed labor, and those kind of things with early marriage, but also, you know, as I said, the mental health implications. One other issue that we can see, maybe not so much in the Terai, but what we can still see in the mountains a lot, is a practice of women, when they have their monthly period, having to go outside to a cowshed, and for those 5 days every month, be isolated from the house, be isolated from the family, and basically sleep outside. And a cowshed isn't like a stable or anything like that. It's really a little shed where they have to be, whether it is winter or summer, and be there on their own. And that is also traditionally where women should give birth on their own. So obviously being very unhygienic conditions, and also being on her own. So that would be two of the really maybe major cultural practices that I can think about that would have a really big impact on maternal and child health.
Thanks, Inge. Alexa had a question around skilled birth attendants and referral. So I'm going to see if unmuting Alexa's audio gives her the chance to ask that. So Alexa, you should be able to see your question now.
Okay, hi Inge, it's Alexa here. Thank you, that was a great presentation and great to hear about the work that you're doing with INF, and yeah, fantastic. I just was wondering, obviously with the government hospital or the health posts with skilled birth attendants, and obviously if women are getting needing referral, that's obviously a big issue, I guess, in many of these districts. Is the government putting more or making more commitment to have skilled birth attendants that have those necessary skills, or are there more referral centres being set up in these districts, or is that not happening?
Thank you, Alexa. Nice that you could join us. Yeah, referral. I mean, every health post should have at least 2 skilled birth attendants in order to run a 24-hour service. But referral really remains a very big problem and issue. And there should be, and there are commitments to have, you know, options for doing a cesarean in every district, but we actually don't have that even in every district. So in the mountain areas, a woman might have to be flown out, and with all the delays in, you know, getting to the service, with the delay in being referred, with the delay in getting a flight, that's actually where a lot of the serious complications happen. So when we talk, and maybe one thing that I didn't mention, but I think that might be quite important, because I can see there's a lot of midwives online tonight. One issue in Nepal is, so with the Millennium Development Goals, the government was really focusing on this skilled birth attendant package that they rolled out, but the level of skills that are taught in that package are actually not at a level of a professional midwife. And up to now in Nepal, we actually don't have an established midwifery profession. It's very encouraging to hear there's a group of women in Kathmandu who have been really pushing for this and have said, have lobbied and advocated at the government and have said we need a professional established midwifery profession in Nepal. And it's very, very encouraging to hear that the first intake has happened. I think they're in their second year now for Bachelor in Midwifery. 15 women in Kathmandu, and I just heard that in Jumla they're going to open another school. So that's a very, very important step in the right direction, because we know from research that countries that have a well-established, well-supported midwifery profession, that actually the maternal mortality rates go down. And the skilled birth attendant was a quick fix. It was good. It did its job, but I think now the country is really ready to take that further. And as I said, it's very encouraging to hear that is starting to happen. Does that answer your question, Alexa?
Yes, that's great. Thank you.
We have time for a couple more questions if anyone has them, or even just a comment or any feedback. So let me just give you a moment to reflect. And while you're doing that, just on behalf of everybody, I'd like to say thank you so much, Inge. That was a really engaging and informative presentation. I heard a sort of scaled down version of that presentation this morning, and hearing the full version tonight, I learned a lot. And the connections that you've drawn between a whole range of factors impacting on mothers' health and children's health. I've learned a lot and really appreciated the work that you're doing and the contribution that you and INF are making in Nepal. So let me see if anyone has any more questions. I think on behalf of everyone, I'd also like to say thanks, guys. Thanks for working for INF. Thanks for being in Nepal. Thanks for coming and sharing with us here in Australia.
Thank you, Ben.
It looks like we might not have any more questions. I won't close it off just yet. Deborah saying thank you very much, really interesting. For those who joined late, I'm Ben Thurley. I'm the Relationships Manager for INF. Dr. Inge Baumann-May is Public Health Advisor for INF Nepal, based in Nepalganj in Banka district, but working across the organisation to work on our maternal and child health work there. This is the first webinar that INF has run in Australia, and I'm just pretty impressed with how it's gone, and think we couldn't really have asked for a better first presenter than Inge. So thank you again. We do intend to run these again, both with friends who join us here in Australia, but also with some of our Nepali colleagues. It's a great way to have them sharing their work directly. So for those who've joined today, I'll send you just one email to send you the link to the presentation, to thank you for joining, and to invite you, if you're not already in touch with INF Australia and the work that we're doing, to stay in touch with us. If you'd like to stay in touch, if you reply to that email, I'll put you on the list. If you'd rather not hear again from us, that's fine. Just either don't reply or reply and tell me you loved the webinar, but you can live without some emails from INF for now, and we won't add you to our database. But look, I think if you could just all join me, maybe via chat, in thanking Inge very much for her time. People are already doing it even without me asking. And oh, I even got a little shout out for my moderation and technical support. It was actually super easy. Inge did all the hard work. So thank you, everybody. Inge, I don't know if there's anything you'd like to share before we close.
Yeah, no, I just want to say I also really enjoyed this very much. It was, we weren't really too sure how it would all go, but get me started talking about maternal and child health, and I won't stop easily. Anyway, thank you very much, everybody. It was great. I can see some of the names appearing on the screen, and thank you for your interest, and thank you for your interest and support and everything. And it'll be good to keep in touch. Namaste.